go into our first pre-recorded pitch, and that it will be from Lars Greiten from FibriCheck. Go ahead, Lars.
Just imagine, what if you could install an app that transforms your smartphone into a medical device to timely detect cardiac arrhythmias and prevent strokes from happening? That is exactly what we're doing at FibriCheck, and we're bringing seemingly simple but incredible sophisticated cardiovascular diagnostics to everyday devices. My name is Lars, CEO and co-founder of FibriCheck. For us, it all started back in 2014 when my father, who suffered a stroke due to undetected cardiac arrhythmia called atrial fibrillation, and he fortunately survived but underwent an intensive rehabilitation path. Atrial fibrillation, or AFib, is an irregular heart rhythm condition that can cause blood clots to get up to the brain, weakens the heart muscle over time, so you develop heart failure and increase your mortality rate with a threefold. There's a 1 out of 3 lifetime risk. It grows in prevalence with age. You're not always aware that you have it, and it's even more prevalent if you have other comorbidities such as hypertension and diabetes. There are today 200 million people who actually require ambulatory ECG testing to check for arrhythmias, but only 20% are being serviced, and 80% of those tests have no specific findings because arrhythmias can come and they can go. This results in a big waste of healthcare utilization, drives unnecessary costs up, increase in waiting lines, and reduces access to the much needed care and lowers the outcomes accordingly. This is exactly where FibriCheck comes into play. We're using commoditized devices that are already available in our pockets. We upgrade those devices with a piece of software, and if you have a smartphone, it's just as easy as putting your finger for only 1 minute on the camera of the phone. We get a PPG signal out of this that is sent to our regulated AI platform that has been trained on millions of data sets from more than 600,000 users and generates the best-in-class diagnostic result for this type of technology. Our results are aggregated in actionable reports, is available through an accessible portal, and can be seemingly integrated into the electronic medical records. We are unlocking global market access. We're a fully regulated medical device in Europe. We've received last week FDA clearance in the US. We're capable of detecting up to 14 different arrhythmias. We have 5 blocking patents inside and outside of the US. We have the world's largest annotated PPG database from more than 16 million measurements. And we're using that data to develop new AI models for other cardiovascular conditions and are creating the ability to look into the future where we can predict certain events that will happen. We are compatible with over 17,000 different smartphone models and wearables, making us a very unique tool that brings us across the entire patient lifecycle. We guide unknown patients to the doctor. We aid doctors in finding problems they could not find before, and we provide diagnosed patients with remote monitoring solutions accordingly. If we compare ourselves to other FDA-cleared devices, we are the only one that is available across platforms, is software only, and does not need a specific hardware device. We can do multiple cardiac arrhythmias. We have the highest accuracy, which we demonstrated in a comparative clinical trial. We have the highest data quality rate, and all of this based on an optical PPG signal instead of an ECG signal. Our value proposition for patients is access to care. For providers, it is increased care coordination and workflow efficiency. And for payers, we reduce unnecessary healthcare utilization. Our business model is a B2B2C model with 2 million annual recurring revenue that is coming from Europe, Middle East, and Australia, with more than 50,000 monthly active users, generating more than 300,000 new data sets per month. We have 60 hospital systems and over 10 international insurance providers and integrators, and we've demonstrated a higher detection yield versus lowering the costs up to 50%. In the US, we've completed a multi-center clinical validation study, received last week our FDA clearance, and we can use the RPM CPT coding for a solution, meaning that patients does not need to pay out of pocket. With over 1 million downloads that we have on iOS and Android, our average age of our users is 64 years old, is very compliant, driving a very high usability, and I'll let our App Store rating speak for itself, which demonstrate excellent results. We have a team of 22 FTEs that just know how to get things done in a very capital efficient way. We're advised by renowned specialists from renowned institutes within the field, guiding us forward in this interesting right direction. We've raised 11 million to date. We're kicking off a late seed raise of 8 million with 3 milestones ahead of us. Increase our ARR to 4 million, validate our business model in the US, and demonstrate our health economic benefits within the US, which will gear us up for a Series A round, after which we will foresee an exit scenario where exit partners are medical device companies in the diagnostic, RPM, or therapeutic space. So I want to thank you all for your attention, and if you want to try our application for yourself, go to the App Store, download the app, and enter this code to get it checked for yourself. Thank you.
That is outstanding. And so let's take some questions from the judges and with Lars. Lars, if you could tell us a little bit about the value creation that you bring to the system through your digital intervention.
Well, it depends on which patient population you're looking at, but mainly it means access to care is the primary reason and the value that we deliver, because people have to wait a long time before they either see a physician or get the right diagnostic, and therefore it takes longer to get the right treatment. A lot of people don't know they have a problem, and therefore you're able to access and help all of them. So it really depends on which patient population you're angling, but it's providing value across that entire life cycle. What's rather interesting is that the elderly population, which is actually suffering more from this condition than the younger population, has now really access because the device is in their pockets already. They are the ones that have a smartphone. They don't have a wearable yet. So that means that you're able to address the needs in that population specifically.
Okay, that's great. And then I know that Glennis has a question as well. Glennis?
Yeah, I wanted to find out, how do you plan on winning the physician recommendation? You're a B2B2C, and I'm assuming the plan is to get the physician to prescribe or recommend, and then the patient will comply. But currently, physicians are incentivized for remote monitoring, and how are you incentivizing physicians beyond improving outcomes?
Yeah, so in the US model, that there's differences with the European model. So we take the learnings we have from Europe and we try to translate them out into the United States. The incentivization for physicians is that if you find patients with this problem, there are specific therapies and interventions that are driving their incentives to make this happen. So if you get a patient early diagnosed, there are treatments that benefit the outcome of the patient and incentivize the physician. That is one layer. The other one is there are RPM codes, there are CPT codes, and the value that we bring on top of that is that we're compatible with those. But since we're software, there's more margins to be taken because you reduce the healthcare utilization and the cost of the workforce on those layers. So those are two clear drivers that we see today, and those we plan now to validate with our go-to-market in the next weeks and months.
That's great. Thank you, Glennis. And we have another question and from one of the judges as well. Go ahead.
Hi. So, Lars, thank you for your presentation. And I know situations that your solution would be very helpful. My question is around your IP as well as your differentiation between your product and, like, say, Apple Watch and Google Pixel that does heart rate monitoring. So what's your IP that will prevent those type of companies to come into your market? And I'd love to hear your response on that.
So we have 4 patents in place. They are granted within US and outside of US. One of them is on smartphones and how we acquire the data, and therefore that is a blocking patent. So if others are doing it in the same weekend, they're definitely block them on that side. We've also have that model translated to the wearable. So if that model is also used on the wearable device, that's also blocking on those sides. And additionally, you have 2 other patents which are linked to how we train and work with the AI that is based on a very innovative method, how we're doing it. And that's the reason why we get such high performance numbers, where we're even outperforming the Apple ones in the market today. So that is helping us protecting it from the AI side. That's how the IP is organized. I hope that answers your question.
So how much better is this than what an Apple Watch or a Pixel Watch can do? What's the significance? What's the difference?
So when you take the Apple Watch, for instance, there are 2 ways that they measure heart rate. You can either use the optical sensing, which is the green light on the back of the camera on the device, or they have the ECG one, which is a superior one. We've demonstrated in a clinical study that we are better than their ECG capability. So we outperform their best-in-class capability. So that is where we differentiate what is differentiating from that side compared to all the others in the market is that physicians, they can understand and read what we can do. So they can interpret this and clinical decisions based on that data. And we're not only saying you have a condition like they're doing, they're just having a binary condition. We're able to identify 14 different types of arrhythmias. So we are able to get this way more clinically relevant than what they have. And on the other side, you have a complete clinical infrastructure behind that travels the data. So if you find somebody with a problem, you're able to navigate them to the right care, where otherwise they just are alerted and they should take action, which the people are typically not educated to do themselves. So there are different layers of differentiation on that one.
Thank you.
Yeah, that's really well said. Thank you. And then last, but of course not least, Tiffany, did you have anything that you'd like to ask Lars as well?
Yes. Lars, can you talk a little bit about the provider burden perhaps, or how you anticipate on making sure that the provider is not inundated with extra work based off of the great product that you're providing here?
Yeah, so I can only speak from the data, the hard data that we have obtained in Europe, where you see the cost effectiveness going up to 50% compared to what they're doing today. So providers, if they have usual care and you would deploy our system in every care pathway that we go, it is between 50% and 80% reduction in either time spent or device utilization in those pathways. So we don't increase more work, we actually create more free time to spend on more relevant things. So that is a clear value proposition that's linked to that.
Thank you so much.
That's fantastic. And Lars, thank you for, again, a terrific Q&A session here. And on that note, we are moving to our next competitor and our next finalist, David Vignano from Sensoria and Sensoria, I have to get that right. And again, we have the pre-record and then we'll have the live Q&A first. And then first, let's get to Davide's pre-recorded pitch.
David Vignano, and I'm co-founder and CEO of Sensoria. We're excited to be a finalist, and let me introduce you to our amazing team here. I don't have time to walk you through, but we're former Microsoft. We spent a combined 50 years of our lives, professional lives at Microsoft and Intel, and we're building a full platform powered by remote patient monitoring and AI technology to monitor patients at home. It's a truly wearable technology that can be embedded into garments and footwear. We built a full system, which is a cloud plus mobile software system, but we have also delivered patented hardware products, which are comprised of textile sensors and proprietary microelectronics. The solutions that we're building are related to solving real problems. There is a gap in the US, and not only in the US, related to the growing aging population and the available number of clinicians. In the year after the pandemic, 22,000 physical therapists resigned in this country, and the aging population continues to increase. The challenge in monitoring patients asynchronously and remotely is the lack of technology that allows a clinician to monitor gait impairments. We have built those solutions, and I will walk you through some of these examples. The opportunity is substantial, growing from $72 billion this year to over $207 billion in 2028. The solutions that we have delivered I'm trying to actually, in a concise way, summarize them here in a single slide for you. You can see that we can actually inject our sensing technology into whatever the patient decides to wear in the morning. We all wake up in the morning and take a shower and put our clothes on. We have smart socks, smart diabetic footwear. We have and can enable any type of knee brace to become smart. For people in a wheelchair, we can monitor pressure relief exercises all through mobile applications designed with behavioral science to encourage adherence and monitor quality of the rehabilitation for the patient. And then we built a full cloud architecture that allows a clinician to monitor each patient remotely. One example of our technology, as I mentioned, is our smart socks. They are comprised of 3 textile pressure sensors and the full 9-axis IMU. And as you can see, we can monitor range of, center of pressure and balance, and all the primary gait metrics, cadence, time on the ground, the step time variability, and so forth. We've also worked with prestigious academic institutions, including the Michael J. Fox Foundation and Shepherd Center in Atlanta. And we're now monitoring both Parkinson's patients and MS, multiple sclerosis patients, successfully. We're working with some of the top pharmaceutical companies on their clinical trials. Another example of our technology is our smart boot for diabetic foot ulceration. In this country, every 20 seconds, there is an amputation related to diabetic foot. We have built a full system. You see here, the product is called Defender, and all of our sensing technology, all the mobile applications, and all the cloud infrastructure is Sensoria designed and built for them. So Defender is a OEM, a B2B partner for us. And as you can see, both USC Keck School of Medicine and the Baylor College of Medicine have published independent research studies validating that we are superior now to the gold standard. In Europe, we're working with the largest knee brace manufacturer in Southern Europe, in Switzerland, Germany, and Italy as well. And they're leveraging our technology to monitor rehabilitation of the knee. Both ACL reconstructions and total knee arthroplasty patients can be monitored from home using our Sensoria Core microelectronic device to monitor range of motion of the knee, but also self-reported patient data. You see some of our amazing partners and customers on this slide. And as you can see, we have already delivered an aging in place, truly wearable artificial intelligence platform. And we look forward to working with you all to make it available to more patients, both in the United States and worldwide. Thank you, and we look forward to your questions.
All right. Outstanding presentation, Davide. Thank you for that. And first up, we have a question from Glennis, who will lead the way on the questions for the judges.
Hi, another one about the go-to-market model. So it seems like your focus are strategic partners, whether it be big pharma or OEM. What are your plans to go direct? And also, another question is specifically, what is it that your device is measuring? Is it pressure? Is it EEG? What's being measured?
So let me answer your second question first. So we can measure anything and everything that a researcher or a clinician asks us to monitor. So in the case of the sock, you're absolutely right. We monitor pressure, and we also have a 9-axis IMU at the ankle bone level. So we actually see the movement of the limb in space. So think about a post-stroke scenario as an example. You want to see the inside-out movement of the leg as an example. You want to see the foot landing of the foot on the ground. So depending on the scenario, we always monitor one thing: adherence. Patient compliance matters a lot. So we try to inject the sensors and simplify the experience both for the patient and the clinician. We all wear socks, shoes every day. So instead of asking the patient to change his or her behavior, we actually inject the sensors into whatever they decide to wear. Number two, the non-mission specific piece of electronics that you have seen on the sock and on the boot has 7 open channels. So we're now actually testing temperature sensor, humidity sensors, sweat composition sensors. So depending on the chronic condition and the scenario, we can collect this data without changing the PCB, the electronics, which of course allows us for scalability across multiple scenarios. Yeah. As you know, it's very expensive to build a single solution. We think that the way to solve this issue is to build a platform with modular components from the textile sensors through the electronics all the way to the cloud.
Okay, great, thank you. And what about your go-to-market focus? Are you focused simply on B2B?
think of us as the Intel inside or the digital transformation engine of footwear, accessories, and analog devices that patients use every day. So yes, our primary goal is to work with OEMs, very much like Defender is a Florida-based company, but we also are able to deliver direct to enterprise and direct to consumer solutions. So we work with some of the top pharmaceutical companies in the world, and some of our solutions are actually available direct to consumer through our website right now.
Well, thank you.
Fantastic. Great questions. Okay, Yasmin, you're up.
All right, I'm going to go to IP again. So talk to us about what IP you have, as well as I see that you're looking at partners. Have you even looked at partners in the fashion industry that are working on adaptive clothing? I'm just curious, how far and wide are you going to find partners and your IP, both?
No, those are great questions. I think, from the IP perspective, we were fortunate enough to be able to secure very broad patents. So the sock, as an example, is protected by 3 worldwide utility patents through PCT rights. So not only we decided to actually keep the textile sensor as a trade secret. We don't want to share how we build our own textile sensors. Why should we make it easier for everybody to do what took us 6 years to do? Build textile washable sensors is very challenging, but we decided to actually obtained and secured protection for the full system. So the whole sock is protected in that case, just to give you an example. And yes, again, we are the Intel inside of fashion. We think that fashion will come next. There is an urgency to fill that gap that I mentioned between the aging population and the lack of clinicians. That's what we called the Sensoria a few years ago, is sensor fusion plus IA. I'm from Italy originally, so IA in Italian means intelligenza artificiale. So now everybody talks about it, but there is no AI without data. So we want to combine, quantify the data fusion from sensors with voice data coming from not just the clinician, but coming from the patient. Now imagine a time-stamped view of how I feel today combined with the data that come from my clothing. that will enable clinician agents that can augment the clinician. In the healthcare industry, we're lucky that we're not disintermediating job. We need more people to actually take care of the aging population. And so I call this beneficial intelligence instead of artificial intelligence.
I have one more question, and this is regarding your grant that you got from the Parkinson's Foundation. My mom had Parkinson's, so I know all kinds of use cases for this, but how did you convince them to fund you?
It was a journey. As you know, they're a wonderful organization. We obtained a $2.5 million grant during the pandemic. It was a challenge to recruit Parkinson's patients during the pandemic, but the beauty of the work with the Michael J. Fox Foundation is not just diagnostic. We think that there is a therapeutic component. Let me explain what we're doing. You can probably see my sock here, our sock here. Yeah. We're adding little Tesla haptic motors to the sock. So it sounds like you know a lot about Parkinson's for your family history. We can unlock freeze of gait. There is actually a great article that I can share with you, an IEEE article, thanks to the work that we have done on patients in Australia during the pandemic, that actually allows to know that if we engage those haptic motors with the frequency and intensity designed by the neurologist, we can actually unlock freeze of gait, which is the reason why most Parkinson's patients fall on the ground.
Yeah. Yeah. That's amazing. Thank you.
Thank you. Thank you.
Outstanding. Good questions. And then Tiffany, you're up.
Yeah, great. Can you also talk a little bit about the patient acquisition strategy and maybe what what you plan on doing in order for the patients to continuously kind of use the devices over a period of time so you can track longitudinal data?
Absolutely. I think that's why our B2B strategy is so crucial, right? Most of these devices right now that patients wear, think about diabetic footwear, do not create any type of knowledge right now. Mm-hmm. So it is incredible. We know what we don't know. Tiffany, right? Which is fascinating, and that's a lot, unfortunately. Freeze-O-Gate is a great example I mentioned before, but adherence, we're asking patients that suffer from diabetes and suffer from peripheral neuropathy, so they don't feel their feet normally, to tell us about themselves, right? The patients are not equipped to answer those questions. We need technology to help answer those questions. So by injecting the technology into great products, like, again, this is the Defender product. It has been designed by Nike. The same Nike designers that designed the Air Jordan designed this device. It's great to look at. It's easy to wear. It's not a stigma, right, to be wearing this device compared to many other offloading devices in the market that look, quite frankly, less than great. So we're trying to combine behavioral science, data fusion, but also the fashion design. There's like, I want to be seen wearing this thing, right? So it becomes actually a good conversation for me, not just an expression of my weakness or my pain, right? So, which is, one of the reasons why medical devices have a much harder way to monitor adherence, right? So it's adherence is the one thing that we constantly monitor. So our goal is to partner with companies also that do remote patient monitoring traditionally, like, Livongo was mentioned before. Why are we just monitoring traditional medical devices when we can also monitor and create novel data sets like GATE? The science of locomotion was, it was defined in the mid 1600s. It's called the sixth vital sign, and we still don't have a medical device to collect degradation of gait for neurology patients. Why?
Fantastic. Well, thank you again, Davide, for a great presentation and wonderful, wonderful product. Next up, we have the good people from Celcy and Max Wider, and a pre-recorded pitch will happen right now.
Good afternoon. My name is Max Wieder. I'm the CEO and co-founder of Celcy, the automated hands-free cooking solution for seniors. Right now, 90% of adults over 65 want to remain at home. Now, most of this is due to the cost of assisted living facilities or nursing homes, which go for $5,000, $10,000, even more. But staying at home has its own risks, mostly time, cost, and health and safety. And if you narrow that to the cooking side, physical and cognitive limitations of cooking, following recipes, grocery store travel, which is known risks, and unhealthy alternatives to going grocery shopping or cooking on yourselves are also a concern. Now, there's also fall risks through being in the kitchen for long times and fire risks. My wife's grandmother used to put her pillows in the oven to keep them warm, and that's just not safe. Now, the burden falls on the adult children to take care of their parents in order to prepare their meals and give them that overall high quality of life. My co-founder's family was spending an hour driving each way to take care of his grandfather, and that was just not sustainable to do that every single day. So enter Celcy. It's a completely remote end-to-end cooking solution that has both a freezer and an oven all in one, where you can load multiple meals and then from your phone select any of those meals to start cooking. That means you can, from anywhere in the world, start a meal. There's no grocery shopping as they're delivered to your door. They're delicious, healthy meals that are pre-programmed as if the chef is cooking for you, and a very a simple user interface. And let me show you how. So here you can see you just load a meal in, and as you do it, it beeps, a light turns on the app, pop, there it is. At this point, I'm going to show you me cooking it now. I just tap it, and I hit cook now, and the device does the rest. I'm going to speed this up, but the whole transfer process takes about a minute. The freezer opens internally. The meal is delidded from any shelf. The device knows what shelf it's on. Pops into the oven where it does convection, conduction, air frying, and we can do breakfast, lunch, dessert, dinner, snacks, anything that can cook in an oven. So now you can go from, hey, Mom, did you eat today? To, hey, Mom, how was breakfast? And you know they're eating it because the device will send you a notification that the meal is actually taken out of the oven. So we're starting with senior care, which is 62 million people. It's a 1.1 billion market in the food service side of the house, growing double digits. Our beachhead within senior care is the single adults, either recently widowed or by choice. That's roughly a third of these people. Our goal is a 1% market penetration of 200,000 users in the first year. And we have additional markets that we're going to also try to enter over time. We're going to focus more on the B2B side of the house. So we are the only fully IoT hands-free cooking solution for seniors. Now, there's Sous Vide and Tovala. Those are other smart appliances, but they're more like a traditional appliance with a vertically oriented food program. And then there's your more traditional delivery services like Cuisine Solutions or Home Chef, as well as Meals on Wheels, Silver Diner, things of that nature. But because we don't make the food as we are the carrier food, all those competitors on the previous slide are potential synergistic partners that we can add to the list of partners that we've already started talking to that said they want to come on board. Like Keurig, we have a standardized tray so anyone can put their food in it. And then we have an online marketplace of all these different partners where meals are delivered to your door. And with all this automation comes automated meal tracking. And as I've said before, the chef who makes that meal programs how it cooks. So you're getting it a high quality meal for that senior as if that chef was in the kitchen cooking for them. So the meals themselves are $12 on average, and a lot of them are already covered by medical insurance. And the device is going to be $350 if you sign up for a 6-month subscription of 15 meals per month. But we're also looking at getting the device covered by medical insurance as we show quality of life increase. As I said, we're targeting 200,000 users over 3 years, which would make us profitable as our recurring revenue from the meal sales grows from 17% to 22% of our overall revenue. This is me and my team. My co-founder and I have been working for 25 plus years in engineering, hardware, software, as well as project management. We have 4 engineering degrees from Hopkins. We have an extended team with over 100 plus years of experience. 2 of them I pulled out of retirement, as well as a very large advisory board covering the full spectrum of manufacturing, hardware, food logistics, branding, as well as other partner accelerators that we've worked with over the years. And I say years because we've been at this for 6 years, bootstrapping our R&D, filing patents, raising awareness, really building the iterations of the hardware. Because unlike software, you only get one shot of pushing hardware out there. So we actually just last month ran our first beta unit through our production line in preparation for upcoming beta launch. We're raising $1.5 million to fulfill that beta launch, which is building 100 units, which will also fulfill our pre-sold out beta experience. The users in that beta experience actually validate the customer segment that we're going after, which further validates the 1,500 people that we've interviewed over the years to really figure out all the key functionality that we had to build in. So please join us as we help enable independence, save money, save time for better health and better outcomes. Thank you.
That is a great tagline. Well done, Max. And thank you for a terrific pitch. And up first for the judges will be a question from Yasmin.
Hi, Max. This is wonderful. I love your tagline. I looked at your website. That looks really, really nice as well. Here's my question, though. What would you say to a critic that would say, all you're doing is you're solving the issue of moving the meal from the freezer to the oven. That's the time that you are really truly saving, because it is a frozen meal. It's not a fresh meal. So talk to me a little bit about that. And then the second question is around, have you really secured a Meals on Wheels relationship or a relationship with insurance companies that you were talking about? How far along are you in those discussions?
Yeah, so I'll start with the first one. So because we're a completely hands-off device that can be remotely started, we're not just saving the time of the process of taking it out of the freezer and putting it in the oven. We're saving the time of going, preheating oven, and the actual cook time, because from your bed or from someone else's phone, you can schedule a meal to be ready at a certain time in the future. Preheating oven takes 15 minutes, and some meals take 2 to 3 hours to cook, especially if the chef who wants a good quality meal. A lot of people say about why can't I just throw in the microwave, but it's again about quality. When you put something in the microwave, you're getting hot spots, cold spots. You can never get crispy. And then oven at the time commitment. And going back to the ultimate risks of fall risk, standing there, transferring it, dropping the hot meal. There's also a lot of energy waste if you're going after a single meal to preheat a full-size oven and then cook a single-serve meal in there. It's a lot of commitment. And then going back to the monitoring side of the house, that's very dependent on that senior doing that by themselves on their own. And there's no information to their children, to their healthcare provider that they're actually doing it. And with our device, I can start the meal for my grandparent, and then I can get a notification that they took it out of the oven. Also, when I started, I can call them and say, your meal's going to be ready in 2 hours, in 30 minutes. So that's kind of that side of the house. On the food side of the house for partnerships, I had some over there. We don't have partnerships with the big brands. A lot of the big brands that we've talked to want to see us in the market showing validating the usage of this. So we have a lot of smaller food companies, relatively size, that go through licensing agreements to a single co-packer to distribute that. From a insurance perspective, again, it's usage in the market. The showing quality of life has to be a quantitative analysis that we can prove through the data that the amount of food they did, their nutrition, the longevity, the overall quality increase before insurance will then add it as a medical insurance coverage. So we have to go through the process of being out there before we can do it, which is why it was an asterisk saying we're pursuing that. But we started those conversations and we know the process we have to do, but ultimately we have to be in the market to start that process.
And what about with Meals on Wheels? Were you able to run a pilot or anything with them yet?
So it's a lot of a chicken and egg situation. The meal companies, because they have these big co-packer production lines, when they run a production line, they're producing 100,000 meals typically in a 12-hour segment. So they usually will do a licensing agreement to our co-packer in order to do it. But the co-packer is not ready to produce meals until there's units out in the field. So that's what this beta program's for. The funding that we're raising is to push the units out there, take the licensing agreements, produce a small quantity of meals, and get them out there and start getting that actual data of usage.
I think you've kind of answered my question, but Meals on Wheels is the nonprofit I was talking about. But
yeah,
I think you're still working on those relationships. Thank you so much.
With that specific provider, correct.
Yes, thank you.
Fantastic. Okay, Glennis.
Nice. I was a bit trigger happy there. Thank you. So very, very intriguing, and congratulations on getting to beta.
Thank you.
I think, oops, sorry. I think there are several big questions. So first of all, why are you deciding to be a Keurig rather than an espresso? And is there any proprietary packaging? So can anyone, it looks like a standard format of aluminum, of plasticware, etc. So what's the unique identifier? I'm assuming barcodes, but is there any proprietary packaging that people will have to adopt and get into their workflows in order to incorporate into your ecosystem?
Yeah. So the first question, why not Nespresso versus Keurig? And my marketing people would tell me to say Nespresso. It's that higher quality. But one of the key differences is that Nespresso has their own product line first before there's the expansion. And what we want to differentiate by saying Keurig, which is a more well-known household name in the US, first off, is that we don't have an in-house brand and we don't want to take on the risk of producing the food. There are plenty of people that produce food. It's their bread and butter, literally. And so we want to leverage that to offer those chefs who, they make a fantastic meal and then people are complaining because they put it in a microwave or they take it out of the oven too fast. And it gives them an opportunity to have the end user truly experience the meal as it was intended to be. So that's the kind of difference between the Keurig and Nespresso tagline. Your second question, can you repeat it real quick? Sorry.
So the proprietary packaging and the
Yes.
Nespresso Keurig, I think those questions go hand in
Yep.
hand.
So
But
the
I'm
tray
also
itself is aluminum. It's a standard tray, but it's how it's formed. It's the size and the fact that the way it holds the lid on is unique. So it allows you to store the meal covered, but then it can delit it. So it's got the mechanics built in for the device to be able to delit it. The lid, again, is just cardboard, but it's a unique form factor. It's got an RFID tag in it, so it actually allows for a lot more information than the barcode. So your other question.
Oh, okay. And so that your form factor in terms of the packaging can be easily incorporated into food packaging, food packagers. Okay.
Yes.
The other question I have is in terms of the market segmentation and the user insights you have, what portion of the elderly population actually is interested in this solution? Because I can imagine it's not for everybody, but do you have a sense of who is this a critical need for?
Right. So this is where it gets different between the user and the consumer. The end user is the senior, but the consumer is actually their child who's purchasing it for them to provide that peace of mind, provide that, because what is happening is a large percentage of the aging in place, it starts decreasing the amount they eat, especially if they're recently widowed. In our personal experience, that when my wife's grandfather was widowed, we were going over to teach him how to boil water. It was just, he did not know how to do anything. And that is the large segment of people in there. Now, I said it's 20 million people right now that are single, aging in place. And that's why I said, we know it's not for everyone in there. I have my grandmother's best friend is 95 and she's walking everywhere, completely self-sufficient. And it's fantastic. But we understand that it's at least 50% that are going to need this, or their children want it for them for remote monitoring purposes to ensure good nutrition. And because a lot of those meal delivery services, you're locked into one brand. And so what you do is you get meal exhaustion, and it's just a quality of life situation.
Yeah. Okay. Well, thank you. I can relate to the meal exhaustion and the challenges as taking care of an elderly parent.
Yeah.
Super. All right. And Tiffany, you're up.
Just very quickly, Max, are you also thinking about having some partnerships where people will help sign on these elderly folks for these benefits? Just because I feel like those types of partnerships will also help you gain some traction too.
Yeah, so we've actually been talking with a number of traveling nurse agencies that provide that service where they're coming to the house and providing at-home coverage. And one of the things that is always difficult is when it comes to eating, you have to eat every day. So then you start getting this need of care every single day. While talking to them, they can offer this as an opportunity to decrease the amount of physical coverage having to be there. They can bring a large number of meals loaded up and cover them for 2-3 days, depending on their usage amount. And that would decrease the cost, which allows them to get more business. So it allows them to get the foot in the door, while the cost is more so on the food side than taking their pills. They're not forgetful. They're not needing the physical assistance as much, but it's more so for that care. And so we've been talking to them, and so they would help push this out the door as an option for helping reduce the cost of the actual service. All right, thank you all for the questions.
No, this is great. Thank you very much, Max. Well done and greatly appreciated. And for the audience, next up is Dan Scarf, and we are very excited to have Dan pitch on his company, and we're going to the pre-record now.
I'm Dan Scarf, CEO and founder at XRAI. I spent 20 years building what would become the world's largest Microsoft partner. We grew that company to over 600 people and over $100 million of turnover before selling to Cognizant in the summer of 2020 for over $300 million. Whilst I was serving my prison term, I'm in completing my retention agreement. I was back in the UK with my granddad, who, like many 96-year-olds, had lost almost all of his hearing, sitting surrounded with his family, but unable to engage in the conversation. I had this epiphany about why can't we combine real-time subtitles with augmented reality to create live subtitles? And so XRAI was born. Of course, my granddad is not alone. Over 1.5 billion people live with some form of hearing loss. And unfortunately, by 2050, that's projected to grow to 2.5 billion people. But of course, hearing loss is just one barrier to communication. Only 18% of the world's population speak English. Imagine we had an ability to bridge that communication gulf. So with those two challenges in mind, we set off on our mission, which was how can we take all of this incredible AI technology we hear about every day and put it to good use? And we were humbled by the response that we received with national TV news coverage in almost every country in the world. So what is it that we have? There are three parts to the XRAI platform: our glass solution, our Babelfish solution, and our stream solution. So let's start with XRAI Glass. Imagine now that we've got access to the world's best transcription engines, and we can now suddenly get incredible levels of accuracy in conversations, which happen all of the time with friends and family. Now suddenly those conversations can be captured and understood. But now imagine that you're perhaps with a caregiver, someone that doesn't speak English. Now with XRAI Babelfish, we're able to bridge that communication guide and actually facilitate communication in over 140 different languages. But looking at your phone is not the best experience. So much of communication is non-facial expressions. It's the frown, the smile. So we partnered with all of the world's leading augmented reality glass manufacturers to make sure that our software works seamlessly with all of them. But unfortunately, with that flexibility comes confusion. And our users told us that what they really wanted was an all-in-one device made by us, purpose-built for XRAI Glass. So I'm delighted to announce that literally today, we have unveiled the XRAI AR1, an all-in-one solution using some of the latest and greatest technology with our software built natively into it for the first time. We think there's a huge market for this. If you look just at the US, 30 million potential customers, assuming 10% of those would be able to afford it, that's 3 million people, and assuming we could only hit 5% of them, that's 150,000 users who's spending $750 a year is over $100 million of revenue. The translation market is arguably even bigger, with perhaps every citizen as a potential customer. Assuming only 10% would be prepared to pay for it, and assuming only 1% of them with us, that's still 300,000 users and nearly $75 million of revenue. We've seen explosive growth with nearly 20,000 users from almost every country in the entire world. We have extensive defensible IP. We've invested millions of dollars creating this application. It works on any operating system. It works on any AI provider. It works on any device. We think this ability to work with everyone, this agnosticity, is actually what really sets us apart in the market. We have competition, of course, because we do so many things. From a captioned glass perspective, we compete with organizations like Xander. We believe that our glasses are lighter weight, they're full color, they're a much superior experience. We compete with free, of course. Our partners are also our competitors, but we believe that our myopic focus on data security will hold us in good stead with some consumers and certainly with our enterprise customers. From an events perspective with Stream, we compete with organizations like Interprify, but we're able to significantly undercut them on cost. There are extensive abilities for us to continue to innovate. We're really excited about having other people pay for this technology. How can we work with insurance companies and governments to get this technology subsidized? There's huge amounts that we can do to help the neurodiverse. Imagine that we could compress the number of words that people were reading by 50% to help people to be able to understand that information more effectively. And some of these new glasses have cameras on them, which unlock all kinds of other exciting things we can do, such as automated lip reading for better speaker identification. So with that buzz there, my time with you is up, but I'm really honored that you would invite us here as a finalist, and I'm looking forward to your questions.
That's fantastic. And Dan is here live with us as well to take questions, and Glennis is up first. Glennis.
Oh, thank you. Really, really intriguing. So one of the challenges with the older population is that there's sensory impairment along many lines. So it's not just auditory. Sometimes it's accompanied by sight and a host of other issues. So with the glasses, how do you correct for people who have multiple impairments? So are they reading glasses and you're overlaying an existing prescription?
So as part of the checkout experience, you select if you want prescription inserts. You then just upload your prescription. There's a set of lenses that get sent out directly to you. Those lenses just clip onto the inside of the glasses, and then you can use them as if they were your normal glasses. So the text gets displayed about 1.5 meters in front of you. So they tend to be long distance lenses rather than reading lenses they put into them, but it can vary from person to person.
Okay. And in terms of the processing data and the cost associated with delivering this in real time around the world, is that built into your model?
Yes, absolutely. So our subscription licensing cost covers, the cost that we incur from the hyperscalers to provide those services. So yes, that is an all-in-one cost to the user.
Okay. And latency, have you done measurements on that?
It's less than 1 second, probably closer to half a second from audio to text. So it's almost real time. You can't tell any difference really. It's quite incredible.
Okay, great. Thanks.
Fantastic. And looks like Yasmin's on camera. Yasmin, you're up.
Yes. So can you talk a little bit about the Google Glasses and others that are kind of doing some sort of this work, and a little bit more about your competition, and elaborate a little bit more on your IP, why they won't be able to infringe on and do exactly what you're doing?
Yeah, so I mean, the Google Glass were obviously released 10 years ago, and they were sort of the very first set of devices. They were about 10 years too early, so they were a little hamstrung and not particularly useful. But there are a whole range of manufacturers, as I mentioned, that we work with, XRAI and Rainio, TCL, and so forth. Now, the hyperscalers, Meta, Google, and so forth, are releasing their own augmented reality glasses, we think in about 2 years' time. So we have at least a 2-year head start on them. Also, you know, we welcome them. You know, the fact that we sell our own glasses, we also partner with other manufacturers. So when Google release their glasses, you know, you'll be able to run our X-ray software on them as well. So we welcome as many glasses as possible, really. How do we stop them competing with us? I mean, in a way, we don't. You know, these solutions will come. Google will make some of what we make available for free. As I said, you know, we compete with free. And, you know, we are focused on those consumers that don't want their conversations being, you know, used to advertise to them, which is, you know, we hope a number of consumers, but also enterprises. You know, I mean, there is no way that an enterprise will use some free thing from Google. They would much rather pay. And in fact, our software supports deployment into their own clouds. So it doesn't even run in our environment. It's all completely locked away, nice and secure. So our main barrier to entry is just speed to market, quality of execution.
Okay, and just for your use case that you started off with your grandfather and having a conversation at a party, how well does your software do with ambient noises? And, you know, if your grandfather is looking at you, then is it mostly concentrating? Is it easy for it to concentrate on what you're saying, or your sister, who might be sitting on his right, is also talking? How well does it do with that transcription?
So with the background noise, phenomenally well. I was demoing this. I'm actually at a conference right now. I'm at Augmented World Expo, where we are live transcribing 9 stages right now. So hopefully it doesn't go wrong whilst I'm here. But we were at a venue last night. I could barely hear the person talk. It was so loud. Yet the glasses were able to capture absolutely perfectly what they were saying. They have highly directional microphones on them, so they will only capture audio from a kind of 20-degree cone in front of you. So they are remarkably effective.
Thank you.
Fantastic. All right, Tiffany.
Great, thanks so much, Dan. Can you talk a little bit about, right now, is it primarily kind of out-of-pocket pay? I'm assuming this is not reimbursed yet.
Correct, yes, and one of the things that we're obviously keen on is finding somebody else to pay for this. We're only 2 years old as a company. I mean, these glasses only launched 72 hours ago, so we're very, very early in the cycle. But we are confident, because of the quality of improvement of life that we can bring, that, you know, we should be able to get some or all of the costs of this funded by somebody.
Oh, that's great. And do you have a sense for maybe what metrics or what you need to show an improvement in order to get the reimbursement over time?
I guess usage, you know, feedback from users. I mean, we've already had 20,000 people using this, and we've had, you know, incredible feedback from them. Honestly, we haven't even tried yet. I mean, we've just been so busy doing everything else that we just haven't tried. So, but I'm confident that when we do, you know, we've got a great story. We can help people so much, hopefully.
Fantastic. All right. And our last but not least presentation today will be from the finalists from PONS and Ilker, the founder and the CTO. And let's go to the videotape.
Hi, I'm Ilker, one of the co-founders of PONS. In the next couple of minutes, I will be explaining how we're democratizing early disease detection through the deployment of AI-empowered ultrasound outside the hospital settings with a specific focus on aging population. One of the main reasons we started our company is because our father passed away at the age of 65. This was a tragic accident that could have been avoided if he was monitored more frequently, because he was in the high-risk group of heart disease due to family history. This is just one example out of many, as statistics show that by 2030, 1 in 6 people in the world will be aged 60 years or older, and more than 85% of this aging population will have minimum 1 chronic condition. Some of the challenges in healthcare for aging populations include, in rural areas, access to imaging is limited and expensive, and there is lack of healthcare professionals that can provide high-quality care. 77% of adults over the age of 50 prefer to age in place, which means they require healthcare solutions to come to their homes. And most importantly, frequent monitoring of high-risk individuals outside the hospitals is not available. These are the exact challenges we're trying to address as PONS, by converting any mobile ultrasound with AI into a powerful, high-quality data source. We're deploying our imaging solutions and making it available as part of hospital home services and mobile healthcare teams, as well as deploying our imaging pod solutions, which can be seen on the right-hand side inside pharmacies and retail centers and walk-in clinics. Our strength lies in our software solutions, which are device agnostics. Our AI-driven navigation technology, which is the first GPS technology for ultrasound, allows untrained healthcare professionals, such as nurses, pharmacists, or caregivers, to collect clinically acceptable ultrasound data outside the hospital settings. Our patented image enhancement technology makes invisible early-stage disease tissue changes visible and provides 10 times more improved resolution and 10 times more images from a single image. Our AI-driven tissue characterization solutions provide for the first time how early-stage diseases look and advance. Our initial focus area is on breast cancer, and we're further diversifying and increasing the data set size that we're collecting through our generative AI solutions. However, our other potential application areas with respect to the aging populations include heart disease, stroke, and musculoskeletal diseases such as osteoarthritis. We are addressing a significant gap, presenting a substantial opportunity. Current technologies cannot capture high-quality image data outside the hospitals, limiting us to 100 million scans. By bridging this gap, we aim to gather 500 million ultrasound scans, establishing the first disease progression database and a substantial imaging resource that is generating a tremendous opportunity. Our business model consists of partnering with major research hospitals and offering our solutions for patient triaging, reducing overadmissions, and providing high-quality data on early-stage disease, which they can use for improved care. We will penetrate into the mass market by partnering with retail care centers to reach a wider and diverse population and access people living in rural areas. Our second revenue model consists of monetizing the large-scale and diverse data generated through our platform to our Tier 2 customers. We are aiming to provide substantial cost savings to our Tier 1 customers by avoiding unnecessary admissions to the hospitals and improving the patient care they are providing through their hospital at home services. Our Tier 2 customers will have substantial cost savings by improving their clinical trial recruitment and retention efforts, and as well as improving their R&D development efforts by using the information that we are providing them on early stage disease, specifically with our imaging-based tissue biomarkers. And most importantly, by saving patients time to scheduling and getting advanced imaging solutions, our platform offers substantial savings to the patients. Currently, we have an ongoing pilot study with Roche Pharma where we're collecting breast ultrasound scans and liver ultrasound scans from women who are in the high-risk group outside the hospital settings. And due to our very successful preliminary results, we're happy to announce that we'll be starting several other pilot studies with major stakeholders in the healthcare industry. This is the team that makes this possible. Combined, we have more than 30 years of experience in business and medical device development. We have a strong advisory board and partners who support us throughout our journey. I would like to mention one last thing before I conclude my presentation. If PONS technology was available 17 years ago, we would have celebrated this Father's Day with our father. Let's help people and please support us. Thank you again.
Great presentation. Well done, Ilker. And we've got one more round of questions for our judges. Start off with Tiffany. Tiffany, go ahead.
Great, thank you so much. Just a quick question on maybe the go-to-market. So right now, are you screening for patients who would be able to get reimbursement for the ultrasound, or is this truly more preventative? So you are screening for more patients than who might get reimbursed?
Yeah, right now we're basically, the pilot study we're performing is part of basically a research hospital setting, which patients are part of hospital at home services. So they are being monitored more frequently, and we're showing that this data can be collected outside the hospital settings and everything is sent back to the hospital. So the data that we are collecting becomes part of the patient's electronic health records. So this is the route we chose. And then But our ultimate goal is to reduce the price of medical imaging to $15, $25 so that anyone can afford it without medical coverage.
Got it. Okay. Thank you very much.
Okay, fantastic. And it looks like we have Yasmin ready to go next. Yasmin?
Hi. So I actually worked for AGFA Healthcare, selling ultrasounds and all of that at one point in my career. I'm wondering why your go-to-market strategy does not include working with device manufacturers that actually do ultrasounds. So that's one question. And the second question is, you had in your go-to-market strategy something like CVS. Do they? I'm not familiar with how many CVSs actually have ultrasounds. So that's my second question. And the third question is, as as we look at the future of radiology with AI, a lot of those images might be read by AI, and they're a lot more accurately read by AI. So enhancing those images, does that, are you focused on the radiologist market, or are you trying to have AI just give the result? I'm not sure I understand your actual steps. So if you can walk us through the use case, that would be helpful.
Perfect. So first question is, like, we're in discussions with Siemens, for example. So as our solutions are device agnostic, they can be integrated to any kind of platform. So we're discussing with Siemens right now, and they're very interested in using basically deploying our software solutions into their point of care ultrasound device offerings. So yes, we are open to work with any manufacturing. Basically, we can work with GE, we can work with Butterfly, Clarius, whoever wants to basically deploy our technology. So we have that advantage. We are device agnostic. The other thing regarding CVS, the CVS is basically providing telehealth solutions to their customers. They're also turning some of their locations to clinical trial centers such as Walgreens. But our significant advantage is, like, there's no technology that exists right now who can provide medical ultrasound imaging in their locations. So we are in very close discussions with CVS right now. They're very open to have this kind of solutions available, because one of the major challenges was, like, okay, ultrasound requires a lot of expertise to collect data. So they don't want to train their personnel already who's overloaded with other things. So our AI solution, the navigation that I mentioned, can any kind of person, like a healthcare, like a pharmacist or a caregiver or nurse who's basically deployed in these locations, can collect data without any training. So that's our significant advantage. And when we're discussing that with CVS or Walgreens, they're very open to solutions that can provide this technology, such as the ones that we have mentioned. And regarding ultrasound, so what we're doing is, like, ultrasound is a very great imaging modality, cost real-time imaging, non-invasive. But one of the significant disadvantages of ultrasound is, like, imaging early stage disease is very problematic. And because of that reasons, all of the competitions that I showed in our slide, they don't really enter the early stage imaging field. They usually try to segment anatomy from ultrasound scans, which is a much, much easier problem, and then try to do measurements and then provide that information back to the clinicians or radiologists. What we're trying is basically, for the first time, our patented enhancement improves the visibility of early stage disease, and our AI solutions can provide additional information. But what we're doing is, we are not doing diagnostics. We're collecting the data, providing the information, enhanced results, sending everything back to the doctors. The radiologists can look at the collected data, they can look at the enhanced images, they can look at the AI disease likelihood index score, and then basically decide what they do. If something that was not on the scan, let's say 3 months ago, at that stage they can say, look, this tissue was not there, or a tumor or nodule, come back to the hospital, we can diagnose you. And our platform also allows patient triaging, which all the research hospitals are very, very interested in that. They don't want, basically, they're mentioning that not everybody has to be at the hospital. We want to basically provide care outside the hospital settings. And if you can provide us patient triaging solutions, we would love to have that available to us. And that triaging can be used also for radiologists. When they go back to their offices next day, only the high-risk patients will be shown to them through our platform.
So if I go to CVS after your agreement is done, somebody there can do the ultrasound. Yes. Do I get to see the results on some app, or does it go directly just to my provider?
It directly goes to your provider, but it becomes part of your electronic health records. And then you get contacted to the provider if they see something that wasn't there visible.
Okay, thank you.
Ease of access to medical imaging. It's like, we've spoken with many especially on the breast cancer imaging side, like it's very challenging to leave your daily life, family life, to go to the hospital, come back. Like pharmacies exist everywhere, and especially, and the other thing is in the rural areas, we can access more underrepresented communities and then minority groups as well.
Fantastic. Great questions. All right, Glennis.
Yeah, great. Thank you. Really, really intriguing and potentially impactful. So several questions. So in terms of liability, with any diagnostic tool, usually a major economic consideration is the liability, and that's for the device manufacturer, for the technician executing, the physician actually making the diagnosis. So have you done any studies to look at your false positive, false negative rate? I'm assuming with greater resolution and amplification by your AI platform, there'll be more things seen, but would physicians know how to interpret those?
Yeah, that's a fantastic question as well. So our GPS technology has more than 90% accuracy. And then again, we're not doing it in diagnostics. All the data is sent back to the hospitals, the clinically basically doing data collection. The AI identifies, oh, this is the clinically correct location. I'm collecting, hold still. Once the data collection is finished, everything is sent back to the hospital. The radiologist can log onto the system. They look at the data. And then they look at the image enhancement results. They look at the disease likelihood index. So we have done several studies using our basically platform. We're achieving more than 90% accuracy in disease identification. We have done qualitative results. We have shown original ultrasound data to the radiologists and oncologists, our enhancement results, and then basically we want them to rate it, right? Like rate it from 1 to 10. Is the quality better or worse? We have, again, achieving more than 90%, more than 60% in image quality improvement. They're very interested in that because, as I mentioned, one of the main challenges in ultrasound, early stage disease identification, is very, very challenging. We are the only technology that is providing them. And again, in terms of liability questions, we don't do any diagnostics. The diagnostics will always be done at the hospitals. We're providing them a platform that can monitor high-risk groups more frequently, get the data, and if they see something that wasn't there 3 months ago, at that point they can intervene, and then call the patient back to the hospital, get a mammography scan, MRI scan, CT scan, or a biopsy, where they will definitely do diagnostics inside the hospital settings.
Okay, got you. Now, for the other component of the patient experience, often patients are sitting there having a scan. They have to wait for a physician or a technician to look and see if the images are okay, and then they come back sometimes and request additional images. So how are you fitting into that type of workflow if most of the actual execution of the scans are taking place remotely? Would there be a suite of people in the background? And also, are you collecting, just want to be mindful of time, are you collecting information about the ultimate diagnosis? So are you requiring that from your clients to get the pathology reports and add that to make your system more robust?
Yes, that will be a basically additional loop that will come back from the hospital, right? Because that will be done at the hospital level. So we are hoping that by combining our imaging solutions or imaging data that we're providing and tissue biomarkers with their biopsy results or additional tests they do, we can further improve the AI, but that will be implemented inside the hospital settings. We won't have access to that, or we will have access, but then the software solutions will be implemented at the hospital. And then in terms of patient experience, as I shown the imaging pods, like it will be a totally enclosed environment. You will go, the pharmacist or caregiver will scan you, or you can be scanned at home if you prefer that. If you're part of a hospital at home services providing center, then you can be scanned at home. So it's then, we've spoken with like hundreds of patients, especially in women breast cancer. They want basically, if they can be scanned at home, they prefer that. They can pay basically from out of pockets just to avoid going back and forth. I heard from a very senior level VP, scheduling an appointment was easy, but she had to wait 3 months to get a scan. So we in our platform, you don't need that. And especially the other thing I mentioned in rural areas, these areas are becoming medical health deserts. We really need technologies like that so that we can provide high quality imaging to those who are in need.
Yeah. Well, great. Well, thank you.
Thank you.
Yeah, thank you both. Thank you, Glennis. Thank you, Ilker. And thank you to the audience. Really, really phenomenal audience. Lots of good questions coming in the Q&A in the chat room and everything else. And it's great to be linked in with you all as well. Thanks for adding me to your LinkedIn connections, and looking forward to following up with you afterward.